Hello, everybody at the AF Symposium. Thank you so much to the organizers, Doctors Ruskin, Reddy, Musa, uh, everybody. I'm sure I'm forgetting some names for having us to present this case on PFCA, which is pulse field cryoablation. We're doing a case here at Medicover Hospital in Warsaw, Poland. And I'm so happy to introduce my colleague, Dr. Paweł Durejko.
Hello.
He has done so much work to find the patients, to make all of this case happen. So, Paweł, on behalf of myself, the whole Adagio team, thank you so much, and thank you to Medicover Hospital for doing such a great job. Thank you.
Thank you, and I'd like also thank Dr. Atul Verma and Adagio Medical that we can use this unique technology, and we are very happy that we can be the part of this story. Thanks a lot.
No problem. It's a pleasure. So maybe, Paweł, do you want to give a little summary of the case that we're doing today?
Yes, just a few words. It seems to me it's a perfect patient for this procedure. Our patient is 60-year-old man. He suffers from atrial fibrillation for about. He is in atrial fibrillation for the last 18 months. And what we would like, apart from this, he has any other comorbidities, so he seems a good candidate for ablation for us. And what we would like to do is to isolate the veins and also to isolate the posterior wall. And it seems it will be a good choice for him.
Yeah, that's great. I agree completely. I think that's the right approach for this patient with persistent atrial fibrillation. A lot of people will ask, why combine pulse field with cryoablation? Can't pulse field just do all the work by itself? And the answer is, in theory, it can. However, all of the current pulse field systems right now are optimized to tissue depths of about 2 to 4 millimeters. And if we want to get deeper with pulse field, that means we've either got to increase the voltage or increase the number of packets that we deliver. And that in turn potentially increases the risk of microbubble formation, incidental heating, as well as skeletal muscle contraction. And so in order to be able to deliver much higher voltages than the traditional PFA systems deliver, what we're doing is we're first doing a subtherapeutic cryo freeze on the catheter. So we're only doing a short 30-second freeze at minus 196 degrees Celsius. Once the catheter is frozen, the PFA in very high doses is delivered. We only have to deliver one packet of 20 pulses because it is such a high voltage, and we can get a good therapeutic effect. And because of the ice, there's no bubble formation, there's no skeletal muscle contraction, there's no incidental heating, and the ice also gives good contact between the catheter and the tissue, which is also vital for pulse field ablation. So a lot of reasons why we can do this. Now, of course, you might say, well, because of the cryo, we're having to do a warming balloon, and how practical is that? Well, we're doing this out of an abundance of caution. These are the first in human cases that we're doing. And so, yes, we are going to use every precaution. But I anticipate we're going to lower the cryo doses to the point where we will not have to take these precautions and we'll still be able to develop these lesions. PFCA lesions in the preclinical work are optimized to 5 to 7 millimeters depth, which are deeper than the traditional pulse field lesions. And so I think we're going to see very durable, good results from this technology. Okay, so right now we are exchanging our regular SLO transeptal sheath with an Agilis deflectable sheath. And you might ask, well, why are we using an Agilis deflectable sheath? Well, as you'll see when I show you the PFCA catheter, the PFCA catheter is a non-deflectable catheter. So we need to use a deflectable sheath in order to have some maneuverability. Let's take a quick look at our voltage map here. So as we're turning around, we see the anterior wall has a lot of normal voltage. The posterior wall is very diseased. The veins are diseased. Keep in mind the patient is in atrial fibrillation, so it's hard to assess voltage, but clearly we're going to have to do more than just the pulmonary veins here. All right, so I'm now going to show you the ablation catheter. So you can see this catheter can assume any shape. It has 16 elements. And right now it has a straight stylet in it, but we can replace that straight stylet with pretty much any shape nitinol stylet, and the catheter will assume whatever shape we want. Without the stylet, the catheter is actually quite floppy. It's like spaghetti. So the stylet is what gives it the shape and the stiffness. So now we're going to deliver a sample of PFCA. So we're going to freeze first and then deliver pulse field into the water. Okay.
I'm freezing now.
Yeah, go ahead and freeze.
Okay, starting.
Full freeze.
I'm the full freeze.
Okay, so you can see the ice forming on the catheter here. It's fully frozen. There's ice all along the catheter. So this is a full or a short freeze before we deliver PFA.
5, 4,
3.
2, 1.
PFA is being delivered. And we just delivered the PFA into the bowl. Of course, you can't see that because it's electricity. Now we're going to thaw this out. But you can see how much ice forms on this catheter, right? It's pretty impressive. And everything tests out well, so I think we're ready to put the catheter into the patient. Everything looks good. So this is the shape of the stylet, the nitinol stylet. It's in a circular shape. And this is the shape that it's going to take once it's inside the heart. We're going to gradually introduce our catheter into the left atrium. There we go. All right, so now we need to go to the left superior pulmonary vein. Yeah, I think this would be a great time. So Powell is reminding all of us that we should be inflating the balloon at this point in time. So I think that's a good idea. Maybe it might, I think it's high enough. So let's inflate the balloon, please. So as I said, we're using this warming balloon out of an abundance of caution right now. We're still experimenting if we can look at even lower doses of cryoablation. We don't need the balloon, but being first in human cases, I think it's very good to be err on the side of caution. And so that's why we're doing that. Okay, so on ice, we see that our circular catheter is nicely in that large left superior pulmonary vein. We also see that on cardo. So we have a nice ice image, we have a nice cardo image. Everything is confirming that we are in the right location. For those of you who like fluoro, you can see that we are also in a very nice location on fluoro. I'm going to turn it a little bit more anterior so we get more of that ridge. And we are going to advance a little bit so that we're a tiny bit right on the ostium of that vein. We don't see a lot of signals here because, he's in atrial fibrillation and the atrium's quite diseased, but I think we're going to get nice results. So let's begin with our let's charge. So the way this works is we start the freeze. It's a total of 30 seconds. 24 seconds into the freeze, 23 seconds into the freeze, you're going to hear a 5, 4, 3, 2, 1 countdown. And at 28 seconds, in the last 2 seconds of the freeze, we're going to deliver the PFA. Okay, so let's get ready to freeze. Okay, we're delivering the freeze. And then at 23 seconds in, we're going to do a 5, 4, 3, 2, 1 countdown.
5, 4, 3, 2, 1.
PFA.
PFA.
And PFA was just delivered. And I know that the electrograms were not large to begin with, but now these lines are completely silent. They are totally silent. So really, single shot, we can get total isolation here, which is quite amazing. And I don't know if you were noticing, but did you see any microbubbles, Powell? No. So, you know, because of the ice, we don't get any microbubble formation whatsoever. We also get better contact with the tissue because the catheter is frozen to the tissue, and that's important for PFA. Contact is important. We certainly haven't seen any skeletal muscle contraction either, so no phrenic or skeletal muscle contraction because we're focusing the field in the ice. The ice is acting like an insulator to prevent stuff from happening elsewhere in the atrium. We have the patient under general anesthesia, but we do not have the patient under any paralytics whatsoever because we want to see if there's any skeletal muscle or phrenic recruitment. We also want to be able to pace the phrenic nerve, so there are no paralytics on board. Let's move a little bit more on the posterior aspect of the left inferior vein, which is right here. This is new stuff that we have not done before. So now you can see I'm more on the posterior aspect of the antrum of this vein, almost on the posterior wall. Let's charge, please. Freeze starts now. Excellent. We're getting the freeze. And I really love the sound effects that comes from the freezing mechanism. This sound that you hear sounds like church bells or something like that. It's really cool. I love it.
5, 4, 3, 2, 1.
Pulse field delivered now. Again, absolutely on ice, no microbubbles whatsoever. None, and the electrograms are completely gone. Really quite impressive. We're going to now move a little bit further on the posterior wall because we're going to be taking out the whole posterior wall for this case. And I think this would be a great place to charge the catheter. We're right over this diseased segment of the posterior wall. Freeze starts now. Okay, good.
1 pulse.
Tiny whiff of microbubbles, hardly any at all. Really quite impressive. And no skeletal muscle contraction. So that's another thing I should mention is that when we start delivering very high voltages of PFA, we can start to get skeletal muscle contraction, phrenic nerve recruitment. We'll see the patient jump or the phrenic jump. And with the ice insulating the electrical field to the area that we want, it prevents us from seeing the skeletal muscle or the phrenic recruitment. There's another place here on the posterior wall that I think would be great to deliver on. Great. Let's do a freeze here, please.
Freezing starts now.
Okay, we can see on ice here, we have a great view of the catheter. Again, as it freezes, you're not going to see a lot of ice on ice. 1, deliver PFA. Oh, no microbubbles, no skeletal muscle recruitment, no phrenic recruitment. and no potentials either. It's very unlikely that we are going to get the phrenic nerve with PFCA. Having said that, in order to be extra cautious with these first-in-human cases, we are going to pace the phrenic nerve, and we are going to do something called cryomapping, where the catheter only goes down to about 80 degrees Celsius. It cycles on and off. We see if we stun the phrenic nerve, and if we do, we know it's not a safe place to go on. So we're going to start off with phrenic nerve pacing, and then let's charge.
Let's face.
And you can see here
Okay.
that the the diaphragm is moving because we're pacing it. And now we're going to start with cryomapping before we do the freeze, okay? So we're charged, so let's do cryomapping, please.
Try nothing is starting now.
Okay, so we're starting the cryomapping. Remember, this is only half temperature, -80. It cycles on and off. We're just seeing if the nerve stuns in any way. And so far, I don't see it stunning in any way.
Two, one, pulse.
No microbubbles seen in the left atrium at all. And very clean delivery. Yeah, I like where this catheter is now. It's sitting right in that right inferior pulmonary vein. Okay, so yeah, go full freeze starts now.
One, pulse.
Okay, no microbubbles, no phrenic recruitment, no skeletal muscle. So it looks very good. Really complete elimination of the potentials. Now, it is true that pulse field ablation tends to stun the cells, and therefore you can lose the potentials very quickly. And so the question is, are we really making durable lesions when we lose the potentials, or are we not? To a certain extent, this is empirical recipe making. And we know from the preclinical data that when we delivered PFCA lesions in an animal model, we were getting 5 to 7 millimeter depths, which is significantly deeper than what we get with traditional PFA that's in around the 2 to 4 or 2 to 5 millimeter depth. So certainly with these short durations, without having to repeat 7 or 8 or 9 or 10 packets, we're able to get significant PFA delivery. Okay, excellent. I think this would be a very good time to cardiovert the patient. Yeah, sinus rhythm. Excellent. So the posterior wall is completely isolated right now. So we have our lasso on the posterior wall. And you can see there are absolutely no signals there. It's very densely isolated. I'm going to quickly go to our right superior pulmonary vein. And we can see that it too is completely isolated here. We don't see any signals whatsoever. I will go to our right inferior vein here. And again, you'll see it's very densely isolated. There are absolutely no signals there. I'm going to go to our left superior vein. And if I look at the left superior vein, we see that it too is quite isolated.
Pace from 3-4.
3-4, there may be a tiny little late potential. We're going to pace on 3-4 to see if it captures. Yeah, I just have to bend down a little bit. There. Left inferior vein is completely isolated. So at this point, we're going to wrap up the case. We have nicely isolated all of the pulmonary veins. We've also demonstrated complete isolation of the posterior wall. The patient was cardioverted back into normal sinus rhythm successfully. Um, Dr. Draco, I want to thank you so much for making this all possible. It's your patients. Thank you for doing the case with me. And thank you for having Medicover Hospital here in Warsaw, Poland, participating in this symposium. It's been a pleasure and an honor for me.
Okay. And the pleasure is also mine. And there will be more thanks to Dr. Verma, to Adagio medical team, but most and foremost for my colleagues from Medicover Hospital. Nurses, doctors, management, support from Bowsons Webster. Thank you very much for all of them.
Yeah, thank you. It doesn't happen without a team, and there's a whole team behind here that's done tremendous amount of work on the technology, on taking care of the patient. Thank you so much to everybody.
Thanks a lot.